Thank you so much. Really excited to be up here today with Dr. Forrest, and I think you wanted to say a few things.
Yeah, so the intention of this session was, and I think Erica said it great this morning, that what we all need to do is learn from each other's mistakes. And I've made lots of mistakes doing this for a long time, so 17 years of mistakes. And so one of the things we wanted to share with you is literally the things that are really important, the pearls that we've learned, things to do and not to do. One of the reasons that Emilie is up here is that, as part of that grant program we talked about, I was actually interviewing her and found out some things about her practice that she was just doing stellar at, just doing a great job at Halcyon Health with. And so she's going to share with you some of her pearls, especially wanting her to talk to you about sort of patient recruitment and retention. And then I'm going to talk just generally about some of the things that I think are some of the keys that I've learned over the years that are sort of the things that make for a good practice and that can keep you out of trouble. But I'm going to let Emilie start things off.
Thank you so much. So my name is Emilie Scott. I'm a family physician and with a DPC practice in Orange County, California, close to Disneyland. My husband and I opened our practice in March of 2016 and haven't really looked back since then. When I first started my career, I started in FQHC working in an academic center and then moved to a large group HMO and then started the direct primary care practice. So let me just get through some of these. Of course this happens. I'm pushing the button. Oh, there we go. So I'll let the slides kind of go through, but basically where I want to start is, for me, the cornerstone or the foundation of a successful DPC practice is looking at your relationships that you build with your patients. So I'm aware of the fact that it's July, and here we have Santa Claus, but I wanted to start with this slide because this, to me, shows how relationships can change everything about what you do in direct primary care. This gentleman dressed as Santa Claus is a patient of ours. And we were sitting in our office doing our work and heard the jingle bells coming down the hall. And he came in dressed as Santa and brought us all a full lunch just to say thank you to us. So to me, this is a way of representing how important it is that we put that first in our goals with our patients. When I look at the direct primary care providers I've met, the theme that I see through all of them is that everyone really values doing the right thing for their patients. There's this sadness about the traditional system and how it takes away our ability in many cases to do the right thing for our patients. And we're burnt out because we can't really do everything in their best interest because there's so much conflict of interest with the way the business model is arranged. So direct primary care opens that up and brings in these doctors who really prioritize doing the right thing for their patients, and that comes out in their practices and creates this environment of success. When Julie and Alicia were talking about setting boundaries and all of these things that can go wrong in the relationship, what I kept thinking was, if you put the investment in up front and think of these people as your family and really look to them as you're there to help them, then these kinds of boundary problems don't really exist. It's important to address them and know about them, but the communication, I think I've heard people talk when they had the panel up here about patients don't call them after hours, or patients wait until 7 o'clock or 8 o'clock on Monday to message you because they didn't want to bother you on the weekend. Nothing is going to help improve our cost that when we think about direct primary care reaching that quadruple aim of improving doctor satisfaction, patient satisfaction, and cost. Nothing is more valuable at improving cost than having that relationship. I have people come to me and they say, I need this MRI. And if I had said to them, I have a headache, I think I have a brain tumor, I need an MRI. And if we didn't have that relationship that we have where we trust each other and we talk about how they don't need the MRI right now, it wouldn't really be effective. It would be more of a contentious experience. But investing that upfront time to really get to know people and be part of their lives, just everything falls from there. So one of the things I tell my patients when they come to see me is, you're driving the bus, and I'm the navigator. So you know your life and your experiences and what you have for your goals, and I have my wisdom and training and my experience, and I can help guide you. So maybe you want the scenic route to the mountains, and I want to think you should go to the beach. Well, it's more important that you pick your scenic route, but I'm not going to let you drive over a cliff. And that analogy carries over into everything we do in our practice. We really try to have the patient be the center of the experience with us. So the technology we have tried to use has really made the patient the center. They see all of my notes. When we talk about communication, they can message me, and we all see everything that we're doing. There's very clear boundaries about when I'm going to respond to messages. But the idea is that they're an active partner in their care. It's not just me telling them what to do, because that doesn't work very well anyway. So a little bit about transitioning from my prior practice to direct primary care. So I was working in a large group HMO, actually United Health Group Optum, and decided I wanted to do direct primary care and knew that I couldn't go and just start talking to everyone about it. That would be bad. So I decided to start writing a blog. And I put in the blog things about common topics that would take a long time for me to explain and would often come up. Like, what do you mean I don't need a pap smear every year? No, you can wait 5 years. And people would look at me skeptically and say, okay, well, go to my blog and read about what I wrote there. And I would give them the details about why they don't need a pap smear every year. So topics like that would go in my blog. And so I kept referring my patients to this blog, and I had a little printout in my practice where I give them the website so they could see where I had my blog. And over time, after we transitioned to our direct primary care practice, we just had that website link over to our DPC homepage. So it helped me get our website out before I left my prior practice. The other thing that helped me with my transition from my prior practice to my DPC was that I put up a review page. It's a little bit risky when you're working in traditional practice to put up a review page. I used Yelp, but I found that it was successful. What you find in direct primary care is any doctor review, you're going to blow it out of the water because it's not an even playing field. We are, in direct primary care, able to provide such a better experience for our patients, so it's worth putting your name out there and owning your reviews because it can be very valuable. So these were some of the things that helped me transition over to my practice and get started. So I don't know if you guys have heard, many of you may have heard of something called a Net Promoter Score. A Net Promoter Score is a commonly used measure to gauge your customer's loyalty. So it's used in business. And so we use this for our practice to gauge the loyalty of our patients. And to give you a sense of the benchmark in the industry, one of the higher Net Promoter Scores is Kaiser, and their score is 31. So you can see with direct primary care, we really can blow it out of the water. And we're not extremely unique in what we do in our DPC practice. This is just by virtue of the model itself. Like Erica was talking about, they had those great reviews. This is just what DPC produces. So in this Net Promoter Score, these were some of the things that people said to us. And I really like this because it touched on so many things that I think make us successful. One is that relationship, that personal feeling that they know you, you know them. They don't come into some impersonal experience and get signed in by a nasty MA. They were talking about the access and convenience. They weren't waiting. And then they also mentioned here about saving cost. So you can see that your patients really will value what you do. So these were some other points that people brought up that I think really makes the difference. I have this belief that patients come in and they actually kind of shamefully say to me, oh, I've been Googling my condition and I'm so embarrassed, but I went on Google. And I say to them, that's not embarrassing. You're engaged in your health. You care about what's going on with your health, and you're trying to find answers. And I'm glad that you are so engaged in looking this up. This is not a dumb question. Let's talk about this very rare syndrome that you likely don't have. But, let's vet it out. And at least you're engaged and you care about your health. So for me, when people can come and they feel that they can come to a physician that's not going to shame them, where they can really be real and tell you their deepest, darkest fears, and you're not going to laugh at them or think they're ridiculous, then they're going to want to stay there. And I think that's what a lot of people are looking for in their healthcare. Like Delicia was saying, you know, her doctor is her best friend. I think, and not to say we should be best friends with all our patients, but there is something deeply involved in that connection with the human that you have as their primary physician. And that's what people want, and that's what they're not getting from a traditional system or even from a larger company. Part of what makes us successful is we can be nimble. If people have a unique experience and the job is tough and we know them well, we can give them a break for a month. So having that ability to really treat people as family, I think, is what makes DPC a success. And this was really cool for me because in my head, when we started the practice, I was so eager and so excited. And when we started, I thought, I'm going to treat anybody who comes to this practice to see me, I'm going to treat them like my family because they invested in me. I took this risk, and I went out and did this, and they're going to pay me money. And I thought, I'm going to treat them like family. And here it came out in our survey when we were doing this, that was the feeling that came across. So your intention really does matter. So behind all the superficial things that you do as far as pearls of wisdom, starting a DPC practice or transitioning, I think the why or the real deep value that you bring is your intention to do the right thing for your patients and always bringing that to them. And I kind of say you're in the business of creating loyal evangelists, right? So if you can get a patient who can basically go out and yell to everyone else how wonderful you are, you're going to be fine. And I think that happens quite easily in this model of practice because the bar's so low everywhere else, so we can easily succeed. So that's all.
All right. Thanks a bunch. Oh, let you hold on to that. Yeah, I'm using this dangler. All right. So, Emilie has been really successful in terms of the practice, and Halcyon has been very successful in terms of recruiting patients from the old practice. I think it's interesting you were in an HMO kind of setup and very restrictive. A lot of times people are worried about going from those restrictive environments and sort of soliciting their former patients. But I think you told me at some point that, like, at this point, almost 40% of your old patients were in your new practice. Is that roughly?
Not quite.
Okay.
When we first started, about half our panel was that. I think I probably had about 200 patients over time. And I've been away from that practice for about 3 years now, and we still have patients calling me. I just had someone join who saw me 3 or 4 years ago in my prior practice, who said, I remember you, and I'm having this problem, and now I want to be part of your practice. So.
And I think one of the things that she mentioned in terms of the relationship issue, this family issue, something I'm always saying to my patients is, I'm not going to refer you to somebody I wouldn't send a family member to. I'm not going to send your prescription somewhere where I think it would be too expensive for me or my family to go. And I think that idea that you treat all your patients the same as you would a family member is really important. But they've done a great job in terms of building a practice really quickly. So. What I'm going to do, again, I've tried to shorten this up some. We could spend 8 hours talking about all the things you should and shouldn't do in DPC. So I've really wanted to focus on the key things, and some of these you've heard before. And towards the end of the slides, I'm going to tell you the things not to do, which is equally as important as the things to do, because some of these stumbling blocks can be real setbacks for DPC practices. So one of the things nobody's really talked about is collections. And, in the traditional model, collections are fairly low. In the DPC model, since you're actually theoretically, potentially charging less overall, your collections need to be really good. So I would say 99% collections is your goal. We have roughly achieved that. At least for the last 15 years, we've been keeping up with that. But the collections is important. One of the things to say real quick, because I don't think I did this anywhere else in the slides, and this is another important pearl, is this idea of membership gap. So anybody in the room who's had a DPC practice for a while knows what I mean by that. And it's where you have a patient come in December, you schedule their follow-up 3 months from now, but their membership terminates at the end of December. So your front desk staff says, do you want to go ahead and renew your membership? And they say, well, no, I'll just renew it when I come back for my follow-up. What happens with that is you've got a 3-month gap. You've just cut your membership fee by 25% for the year. So that's one of the things that is important. I consider that part of collection. So we'll talk about some of the things you can do to avoid that. Membership management software, I thought Erica did a good job discussing how, at the time Q-Liance started, in fact, definitely at the time I started, there was nothing available to help you manage sort of membership subscriptions and certainly employer subscriptions. And now, the technology is better. It's getting better every year, and there's a lot of integrated products. Rather than creating something from scratch, I actually went to the gyms and said, hey, what do you guys use to keep up with your memberships? And they said, well, we use this company, and they process like $62 million per hour for us, and they've been doing it for 25 years. And I said, well, I'm going to go see if they'll process medical payments, because they were very reluctant to do. But they got into that, and that's what we use now. It's called Twin Oaks. But you need something that is going to be robust, whether it's that or some other platform that's going to reliably collect your payments. Don't try and go through a roster of credit card numbers every month and bill them, or try to draft electronically manually from an Excel spreadsheet, which is something else I've heard practices doing every month, because you're definitely going to miss some collections that way, and it's also going to be really tedious, and you don't want to have you or yourself having to do that. The other thing is clearly stated policies and membership contracts. When we first started, we didn't even have a contract. We just said, hey, here's what we'll do. Here's what you pay. Come on in. I think this day and age, it's really ideal that you have a membership contract with every patient, regardless of the source. And you need to outline your policies in there very clearly in language they can understand. It's fine to have attorneys and good folks like Phil Eskew and other folks who are familiar with DPC look at that. But remember, it has to be in language patients can understand to sort of meet the sniff test. If the Attorney General in your state ever challenged you, like happened in our state, you need for them to say, you know what, a reasonable person reading this would know what they were getting themselves into, and it would be perfectly appropriate. So keep that in mind. Same thing go for policies. I thought the last presenters did a good job talking about things like, narcotics prescribing and sort of here's how we do things, and we're going to follow those rules. Having all that stated in your policies up front is going to avoid a lot of trouble. And I've heard it said lots of times that the definition of frustration was expectations divided by reality. So if you set the expectations for your patients, here's what it is, they're going to be less frustrated when they say, hey, can you give me 50 refills of OxyContin? Well, no, and you knew that. That's what we were getting into. This was brought up yesterday. I'm glad, I think Mara talked about it, because she's doing an ultimate micro practice with no staff. But this is really important, and I think a lot of people miss this boat. There are DPC practices that have virtually the same overhead as a traditional practice. And that's not how I made this successful. You could make it successful that way if you started with a full patient panel, but most people who are transitioning to direct primary care or starting from scratch in direct primary care are having to build that panel. And so you need to keep the overhead as low as possible. This year my overhead's running about 17%. The highest it's been is around 20%. But very, very low overhead. And there's lots of things you can make use of. I've told the hospital surplus story before about, renting a U-Haul truck for $19, backing it up to a hospital surplus warehouse, going in, and there was a guy in there named Bubba who Bubba had been authorized that if an offer was made on any of this surplus hospital medical equipment, he could take it. And so I'd say, oh, I like this exam table. How about I give you $100 for it? This was probably a $2,500 exam table that used to be in the cardiac intensive care unit at this hospital. And I basically equipped my practice, initially EKGs, furniture, and everything for under $9,000. So when you're desperate, out of desperation for making things financially work, you've got to make sure to, especially at the beginning, keep your overhead really low. For residents or medical students in this room who would be doing this straight out of practice, this is critically important because you are, number one, you've got debt from medical school possibly. You're starting with 0 patients potentially, so you must keep your overhead very, very low. I started with 1 staff person who I've been very blessed to have for 17 years. That's been terrific. But I think the way Mara described yesterday, if you're really, really wanting to start low, you could even start with 0 staff. Gordon Moore, who started sort of the idea of micro practice, when he did that, he went into a room that he rented from another physician, just 1 room, no staff, and a headset, and did it all himself, but was able to cut his volume from 40 patients a day to 10. So you can always cut your overhead to make this financially viable. You do not need to take out a huge loan to start a DPC practice. Please avoid that. Litmus test, and I talk to people about this all the time. Somebody mentioned it, I can't remember who, about the unsuccessful DPC practices had marble countertops. I think that's absolutely the case. So you will not find mahogany, marble, anything really, really nice in my office. You also, it won't look terrible, but it's not high-end from that sense. We haven't feng shuied the waiting room, and we don't have fountains and bamboo there, okay? So the litmus test is, will spending this money actually improve patient care? And if it will improve patient care, then I'm willing to invest in it. But if it's something that doesn't, then it's not something I'm willing to spend resources on. Technology and automation, as much as you can, make your job just looking after the patient. And let everything else that we hate doing become something that's an automated side note. Oh yeah, that's running over there in the background, but all I'm having to do is go in the room and see patients. Okay, so as much automation as you can do. We talked about membership management platforms. Telemedicine, there are lots of great platforms out there. We've used several. With that, there was actually a opinion released recently about HIPAA and texting that said you actually didn't have to have a secure platform to text from, but that for that or email, you needed to notify everybody in advance that this was an unsecure form of communication. Most of the platforms that are out there that do telemedicine are considered encrypted and fairly secure, and I think you're safe using something like that. A lot of them have other built-in benefits, where they link into the EMR or link into your practice management system. So that can be useful, but don't overspend for these. Telemedicine can be as cheap as free. There are free formats out there. In fact, one of the companies that provides the telemedicine link for the space station has a free version. All right, they're not here, and most people don't know about them, but there's several out there that are less expensive. We've ranged anywhere from $50 a month up to one that's $100 a month. But generally, you want to keep your costs low there. Location. So, again, I told you can make it with one exam room, and you can. I think ideal, if you're starting up a DPC practice and you're planning on, eventually maybe adding somebody else, is between 1,000 and 1,200 feet of square feet with up to 3 exam rooms. Now, you're only going to use one exam room for continuity patients, and you really would only need 2 rooms if it was always going to be you. But if you ever want to add help, you need a continuity room for both of you and then a walk-in room that you can both access as well. But you don't need to oversize your practice and oversize your expense, especially when you're not going to have a ton of volume through this clinic. You're not going to be seeing 30 people a day. One of the best tips I ever got from my accountant, it was an old, wise accountant who's got macular degeneration now, so he doesn't do my taxes anymore because he was looking at my returns like this. But the best advice he ever gave me was, he said, own twice, if you're going to buy your space, own twice as much as you need and rent half. Any of you out there, this is the best. This is not DPC advice, it's investing life tax advice. Because what that does is typically the rent for whoever's renting will cover the entire mortgage for double the space. So literally, I bought 2,100 square feet, rented half. The tenant's rent payment paid the full mortgage. When I needed the space, I kicked them out and bought another 2,100 square feet, rented that out, and that rent paid for the mortgage on both. And in 10 years, I paid off 5,000 square feet, and I never made a payment. And not only that, it was all tax deductible and depreciated and all that kind of good stuff. So the best advice I give, if you're in a position to own your space, financially own the space and rent half if you're not just going to go with the minimum. If you're going to lease, then try to go as small as you can. And it also creates an automatic retirement account. When you retire from DPC, if you have 5,000 square feet that you can rent out at $10,000 a month and it's paid for, your retirement plan is complete. And you can always do that. So that's just a tip. This one is interesting because I get a lot of people who say, do I want to be near another doctor or competition? And you absolutely do. Because in the DPC model, you can outcompete all those doctors. You want somebody to go next door and that doctor say, oh, I'm sorry, I can't see you or your child today, but there's a clinic down at the end. I don't think they take insurance. They do something kind of weird, but they'll see you right away. And I can't tell you how much that built my practice because it was a pediatrician's office down the way. And when little Johnny couldn't be seen down there and they walked him into my office, the mom's like, oh, and I can be seen here too? With this kind of access and an hour-long visit and all of my questions answered? Sure you can. So you want to be near other medical because that's going to draw in people who are dissatisfied with the current system, and they can become aware and satisfied with you. Okay? If you just find a Walgreens or a CVS, let them have spent the $1 billion on market research to find out where they should have put their store, and you get within a block of that. Because they've done all the demographic research to find out where people are who are getting their medical care, driving to and from work, and where they live, and they've put those stores with a lot of research where they think the best bang for their buck is. Well, guess what? Same place you want to be. Option to sublet to other specialists or health professionals. We talked about that a little bit. That works great, especially if they're complementary. Like if you have a psychologist and you need some mental health help, then that's somebody that can benefit from renting space. We've had cardiologists, ear, nose, and throat doctors. Right now we've got some vein doctors next door, so it works out really well. Marketing, lots of folks are going to talk about this, and you actually mentioned part of this a little bit, is making your patients the best evangelists. Some of you have heard this story before, but I got to tell it again because I think it's just classic of how this model spreads. Is on our intake forms, we don't use paper anymore, but we used to. It would say, "How did you learn about our practice?" And all of a sudden, one month, all of these people started writing at a Durham Bulls minor league baseball game. And I'm like, well, I'm not paying for advertising at the Durham Bulls. I don't have billboards there. What's that about? And so I asked one of the patients who had written that down, and she said, during the 7th inning stretch, this woman in front of us stood up, and she started passing out your cards. And she passed them out to everybody she could reach before the song was over. And then she told me, she said, if you're sick of what medical care has become in our country, and you want to be able to spend time with your physician and be listened to, and have it have nothing to do with your insurance, go see this practice. And I had tons of people who put that on their intake form, that this is where they heard about our practice. And I never identified the patient that did it. They never came clean. But that's exactly what you want. If you've got patients handing out your cards at minor league baseball games, you have met your mission. Okay? Earned media is better. I actually have a statewide radio show in North Carolina right now. It goes from Charlotte to Greenville. It actually goes down to Florida and Miami at night. But it's every week. And it's great. It's a 30-minute show every week. But that's still not as good as being the story. Being the story in your neighborhood, first DPC doctor in Alaska, first DPC doctor in this community, doctor tries new crazy method of healthcare. Because let me tell you, when the stories first came out about me, that's what it was. Crazy, insane, odd, I was called all kinds of things. So, but it's really the best advertising you can get. If you put an ad in the paper, if you spend money on advertising, people just recognize that as advertising and flip right past that, right? Think about when you get medical journals and, the drug companies have spent lots of money on ads. You're just flipping right past those, right? Same thing, but if the front page is, here's the story about this doctor who does things really strange, people are going to read that. So be the story. Earned media is very useful. That's actually what made us solvent. About 3 months into our practice, our local newspaper did a story, and up until that point, we were seeing like 1 or 2 patients a day, which is not enough. That means we only had about maybe 100, 150 patients. And the day after that, 200 appointments were scheduled. Now, not for that day, but scheduled out where all these people said, hey, I want to be a part of that. So that can be very useful. When you're transitioning existing practice, now, people who are in non-competes, and Phil can correct me here if he's in the room, but he'll back me up on this. A lot of people are employed by healthcare systems where they say, hey, when you leave, you can't solicit. You can't compete. You can't do anything like that within a certain mile radius. And what most people have argued is that if you're converting to DPC, you're not competing for the same widget, right? That hospital system you worked for, they were selling 99213s. That's not what you sell. You don't sell 99213s and CPT codes. You sell a monthly membership. So you're not competing for the same thing. So in most cases, those agreements, people say, well, they're not really violating a non-compete because they're not competing for the same services you sell. And the other point that people have made is no hospital system will ever bring the suit in the first place, and here's the reason why. Talk about a precedent. Imagine that they lose. Then any non-compete for healthcare in the entire country just became mute, because now all people have to do is say, well, I'm going into a DPC practice, and then non-competes don't matter, right? So it would never be challenged likely. So take advantage of trying to take patients from where you are to where you're going. I also go with our medical board has real strict non-abandonment policies, and to me, if you don't tell a patient where you're going at all, and you're assuming the hospital is going to give them, medical record information and all that on your behalf, you're liable. If somebody needs something that you have or know or whatever, and they don't have it, and a patient can't get it with HIPAA, was one thing, but with your medical board, they could say, hey, you've abandoned your patient. So letting them know where you are or where they can get information about their medical records is always a good way to do it. That's not necessarily soliciting. That's basically telling people, hey, I want to make sure continuity of care exists and that you can get information you need about your further health care. Keep it simple is always really, really important. I think about the dollar store, the elevator speeches. I always tell people, if you start out your DPC practice and you have 3 plans, let's say you have one for X amount, if you're a little bit older, you have one for this amount, and if you're, something else, you have this amount. That's hard to relay in the community. People, they run into somebody after Sunday school class and they say, hey, my doctor's great. He just charges X amount per month and basically takes care of me. That conversation is going to happen every day, all day long. If that same person comes out after Sunday school and says, hey, my doctor's great. For people who are 25 and under, he charges this. For people 35 to 65, he charges this. If you're over 70, it's this. That conversation's never going to happen, right? Number one, the person telling the story, it'll be too complicated to explain it. They're really only going to understand their plan. And number two, the person listening's already tuned them out. So make it simple, especially when you're starting out of the gate. It needs to be very simple. This is a good friend of mine in this picture. Name's Dr. Dennis. And he gave me this picture because this is sort of his vision of what's happened in medical care. And Reed Blackwelder, who used to be president of AAFP, actually shocked me at one point because he said a child who had been asked to describe their primary care experience with their family physician drew a picture exactly like this in crayon. And said, yeah, this is what it's like when me and mommy go to the doctor, and this is the picture he drew. And this is what patients have become accustomed to expect, and their expectations should be better than this. This actually is a series of pictures, and in the third one, the patient's like clutching her chest and on their back, and she's dead because she's been complaining of chest pain the whole time, and he's like, oh, I have to check one more box. I have to check one more box. Exceed their expectations. I use an EMR. My computer never goes in the room, right? I leave it outside the room. I prime myself. Okay, I know their meds. I generally know what they have. The vital signs, staff at my office writes on their labs on the back of the sheet. So when I go in, I know what all their vitals are. I can go in and have a discussion, talk to that patient, examine that patient, basically say, hey, I'm going to leave the room, I'm going to go out, and I'm going to send all of your prescriptions to the pharmacies, and I'm going to type up all of your care instructions so I can print them out, and you'll know when all your appointments are and all the meds you're taking. And they don't mind when I leave the room to go do that. Then I go do my documentation, completely finish my note, and come back. My note's done by the time I come back in the room. I say, is there anything else you need that I can do for you? And they're like, if they have something, we'll talk about that. And if they don't, I'll say, okay, well, I'll walk you up front, and they'll print your aftercare instructions. People understand that when you leave the room in that situation, you're working on their behalf. They're not waiting, number one, so it actually makes them perceive a longer visit. Number two, it makes the interaction between you and the patient in the room, you and the patient. And I don't care if you put the laptop right here and the patient's face is right here, you've put up a barrier between you and the patient that doesn't need to exist. Okay? So just keep that in mind. Changing the copay culture. Now, when people ask me what is the biggest con of direct primary care, this is it. You have to not only sell the value proposition to patients. You also have to sell it to employers. You have to get people out of this mindset where primary care has been devalued year after year after year, such that people are actually upset when they return for a follow-up in most situations that they have to pay another copay. Oh, you're just bringing me back for another copay, right? So their idea is that copay is literally the value of that visit. And we know none of us could make it on just the copay, right? But the perception is it's a copay culture, I call it that. And you have to get people over that hump. So first, there's the financial argument. And you can show about 85% of your patients that if they go to you as a direct primary care physician over the course of a year, their out-of-pocket cost will actually be lower than going in-network and using their insurance. And we've got about 10 years of data from the MBA students have looked at to prove that. But there will be people who have these Cadillac plans. They've paid like an extra $1,000 a month to have no copay, and they've got some kind of 10 supplements. And they're people that when they go in for any care, they don't have to pay anything. And for those people, you can't make that financial argument, but you can always make the value argument. I actually like something Tom White said a couple meetings ago, which is this last thing I'll talk about. But I've always used this liver and mustard sandwich analogy, which is if you say to a patient, if you had a coupon in your glove box that would get you a free liver and mustard sandwich at McDonald's, would you get in the drive-thru and go get it? Or would you look across the parking lot at the seafood restaurant where all of your friends are at that has a senior citizens discount that everybody loves? That's a good value for your money. And they're all like, oh, I go to seafood restaurant. Then why are you using the coupon for the free liver and mustard sandwich? Now, to Tom's example, what he told me he would say to people is, look, how much do you pay for your premium each month? And people say, oh, if it's $500 or whatever. And then he'd say, okay, are you 100% satisfied with your care that you're getting for that $500 a month? Oh, no, not really. That's not good care. Well, if I could just tell you it's only 10% more and you'd be 100% satisfied, would that 10% be worth it? Oh, yeah, absolutely. So you have to get people past the idea that they're paying more for something that they could get for free, because they're not. They're not getting something for free that's as good as the experience you can give them. All right, I've shown this a million times. I think this analogy is just very helpful, both for just primary care, healthcare reform in general. So the insanity of primary care is that we basically pay somebody to bill for everything we do. And it would be just like at the gym. Every time you lift a dumbbell, cha-ching, that's $5. Every time you get on the treadmill, that's $3. And if a gym operated that way, they'd have to have somebody follow every patron around, and everything you did, they'd have to write down. It would cost more in salary to pay that person than your entire membership for the month. And yet that is the exact crazy insanity that primary care is now. So on the other hand, at a gym, I want to make this step too. At a gym, everything's not included. So let's say you go into the gym and you want to walk on the treadmill. Fine, that's what 90% of people do. Let's say you want to lift weights. Fine, that's what 90% of people do. What if you want to go to the fruit smoothie bar at the gym? Is that included for free in the membership? No. You got to pay extra for that. So one of the things, and this also has to do with regulatory compliance, because several departments of insurance have ruled and given the opinion that if at any time the amount of money you spend on a patient is more than what they're paying you, you're an insurance company. You've got risk. You need capital reserves, et cetera, and so forth. So what we tell patients is, look, 90% of what we do, and we itemize that, is going to be included at no extra charge. But if you need something done that's extra, we'll just charge you literally our wholesale price, just our cost. So it's important to remember that. All right, somebody told me yesterday, they love this slide and they use it all over in their presentation, but it's still on a chalkboard at my office because I think this explains the math of why DPC can keep practices financially independent. One of my big goals is to stop this consolidation and having all primary care physicians in the world owned by a hospital. That's crazy. And we know that's worse care. We know that independent primary care, regardless of the model, is better care than care that's institutionalized and owned by institutions. So to keep people independent, how can you make financially this work? Well, on the left, if you charge $1 and you collect 65 cents, which is the average nationally, and your overhead in primary care is 60%, which is the MGMA average nationally, it leaves you 26 cents on the dollar. And if you collect 99% in DPC and your overhead's 18%, it leaves you 81 cents on the dollar, which means that you're actually netting over 3 times more for the same charge. Which, think about this for a second, if you charged half as much, you would still net a 50% higher salary. Okay? This slide right here is why this model works. This is why you guys can afford to do it and why it will sustain independent practice. But if you're not keeping your overhead at those low levels, and if you're not keeping your collections at those high levels, it won't work, and you'll fail. Interacting with patients, especially in the beginning, we got a lot of hang-ups where people would call and say, hey, I saw you were a new practice in town. Do you take XYZ insurance? No, we do something kind of different. 90% hang-up rate, right? Only about 10% of people would stay on the line, and those 10% would basically talk to Susan, and she would say, oh, we do something kind of different. Here's what we do. We don't even care what your insurance is or what you have. We take care of people, and so whatever you've got's fine with us. We don't care. And a lot of those people would come. But you also have to engage the ones that stay on the line and explain to them what's going on. It was a great idea. I think Corey maybe talked about this yesterday, to have that initial meet the provider visit, and there's a lot of you that have done that. I never did that in the beginning, but I think it's a great idea that you say, look, we're going to have a non-medical visit for anybody who wants to come to our office just so I can sit down face-to-face with you and explain how this works. Because you talking to somebody face-to-face and explaining this, you can get through, and a lot of those people will get it, and that will work. And then the key, most of all, is give patients what they want. They want short waits. They want same-day access. They want unrushed visits, not necessarily long visits. I've had patients say to me many times, Dr. Forrest, I got to get to work. Or, Dr. Forrest, I got to pick up the kids at school. Because if I don't have anybody waiting, I'll talk with them all day about their diabetes, So it doesn't have to be long, but they don't want to be rushed. They want all the time that they want, and that's key. We talked about the no technology interference. And then, again, word of mouth is number 1. Earned media is number 2. I've used this acronym before. I think the key with any of these membership, direct care, DPC models, whatever you want to call it, is showing the value. And again, healthcare is local, so you have to show your value to your community. Somebody's not going to be able to go to a website about DPC somewhere and understand what that means for them where they live. But if you're out in their community, if you're at their Rotary Club or their Chamber of Commerce or whatever you're doing on a local radio station getting interviewed, you can explain what this means. So we talked about cost, time, and access. This availability, always seen as one of the key things people want. They want to be able to see you when they need to see you. And a lot of people have talked about the fact that DPC patients don't abuse after-hours call as much as you would think, and this is the reason why. After-hours call abuse is people who feel like they're never going to get to see you. So, and their needs aren't going to get addressed, so they call the on-call line figuring somebody's going to have to get back to them. If they know you're going to get back to them, they just don't do that. And I would echo what other people have said. At our practice, we take call a month at a time because it's just that easy. And even though I have doctors I can split, we do it for a month, and in a month, maybe I have to return 1 call in a month. And that's with a totally full panel. It's just not that bad. Use word of mouth and media. We've talked about that. And then exceed expectations. So I go back to the Disney idea here. Disney's old mantra, and I don't know if that's true anymore or not, but their old mantra was, if people go to a amusement park, a carnival, whatever, we want to be in the top 1 percentile of that expectation. We want to be the best amusement park experience somebody's ever had, and something truly different and set apart. And I think DPC automatically does that. You guys don't have to go out of your way in some ways because the model does that. But you want to make sure that's your gold standard, that you exceed your patient's expectations and that you make it the best medical experience ever. Some of the people yesterday talked about house calls. Tom White talked about house calls. We've done those. I tell you what, when you do a house call for somebody and it's not charging extra, or when you do a telemedicine visit and look at their medicine bottles and make sure there's no interactions, or their herbals and make sure there's no interactions, and you don't charge them for that, they're like, this is crazy. Doctors just don't do this. How is it that you can provide this care, this level of intimate care and relationship, and you're not having to figure out how do I code for that? And a lot of times new docs to DPC, in fact, I'm sure some of the people at this conference will come up to me at some point and say, well, what if you irrigate somebody's cerumen? How do you charge for that? Come on, you got to get out of that mindset. We don't need to nickel and dime people for everything. We want to add as much value into our scope as we can. I'm going to not spend a ton of time on this because I think it's been talked about a lot. I do think that working with employers can do one critical thing, and that's that it can get you a certain number of patients in your panel faster. We've done it since the beginning, literally one-on-one grassroots, riding out to an appointment at an employer and selling our case. Biggest employer we've ever worked with locally was we got 500 patients from a tool company, the people who invented the crescent wrench. But let me tell you about the caution of that, and I think Erica touched on this a little this morning, is that company got sold to Mexico a couple years ago. When they got sold, 450 of the 500 patients moved out of state. That's not a diversified portfolio, right? That hurts. That's a chunk. So I think what's much better is having a lot of employers in your area where you get 5, 10, 20 patients from, right? And there are platforms in place. You can definitely talk with me. Yesterday they talked in the morning about a railroad track that can sort of hook you up with the employers. I can tell you ways that you can do that and make that sort of automatic. But generally you want to use that to build a panel. However, having said that, this is not where most people get their patients. Even folks who do a lot of corporate business, it doesn't represent over 20% of their panel. So you guys have to remember that most of your patients and your customers are going to be individuals. Okay? This can be useful again, though, and especially small businesses in your area that don't have to offer the full minimal essential coverage benefits and all that, and that's going away in 2019 anyway. But places like Subway are really good. Those restaurants, avoid a lot of workers' comp when their employee cuts their finger slicing subs and just can come up to my office and get it stitched for free. They don't have to make a workers' comp claim, right? So businesses like that really appreciate DPC. And again, I'm going to go back to the fact that I don't care if you don't want to submit any data at all. That's fine. But a lot of the other of us are going to do the work for you because we believe enough in this. We've got to make sure that it succeeds. And so people want quality outcomes and cost data. And if you're going to work with employers not Subways don't care, but if you're going to work with an employer that has over, say, 150 employees, they're going to insist on knowing, number one, their patients are actually being seen at your practice. Number two, that there's some level of quality assurance there, and that there's some level of satisfaction that's gauged for the employees. So there's got to be something there. Keys to making it work. So this is sort of my summary. The most important things. Keeping your overhead low. Now I have worked with some practices that we've helped in places like Connecticut. I never knew in Connecticut that real estate was so high. We generally have a budget for people that we say to expect for their space, their facility. And in Connecticut, for this particular group of physicians, it was 3 to 4 times that. So it's really hard for them to keep their overhead under 25%. But you need to do everything you can to keep that overhead low. Second thing is, you don't need to worry about the money. You don't need to worry about the billing. But you need to make sure that in some way you're reliably getting paid for all these memberships. And I'm not talking about when people don't pay. I'm talking about when things go wrong. For example, you guys probably remember the Target ID theft thing a couple years ago? And Target had lots of people's credit card numbers stolen. Well, guess what? All those credit cards got canceled. If I had been doing it the way I used to a long time ago, which was through PayPal, or if I'd been manually entering that, I would have lost a ton of revenue. Instead, immediately, as people came in our system, it basically, the screen lights up green if everything's good and red if it's not. If everything's not up to date, it turns red. And we were notified immediately, and all we had to do was just tell patients, hey, what's your new number, what's your new expiration date, and everything was fine. But that month, we had that come up like 15 times. So you've got to make sure you've got an automated way to keep track of that. PayPal was awful, by the way. I don't encourage anybody to do it that way because it's hard to track histories and the fees are extraordinary. Overpay the copay culture with value, as we talked about, and then the flexibility. So, again, I think it's been said there's no one way to do DPC, and in fact, you're all individuals. And I really want people to be able to stay in independent practice and be able to do it the way they want to do it. And part of that is responding to the needs of your patients. Okay, so I'll never forget, a few years back, I had a lady, at the time, for INRs and stuff, which we don't even hardly do anymore, but for INRs, we had a fee. And it was a low fee, but all of a sudden, patients stopped getting their INRs done at our office. And so I asked one of the patients, I'm like, what happened? And they're like, well, with my insurance, it's this. And then we had other patients say, well, even without insurance, I can get it at this Duke laboratory for $2 less than here. And I was like, oh no, that can't happen. So I instantly, as soon as I got that feedback, I went and I tore up about 500 copies of our encounter form, and we printed up new ones that afternoon with a new price. So that's competition, free market at its best. We met the need and nimbly changed. You can't do that in a university or hospital system. If a patient came in and said that, and you're in a system, they can't go change their prices like this, but you can. If there's a policy that doesn't work, I love that they have that Net Promoter Score, which is a great way to get patient feedback. We send out surveys, tell us one thing we could improve, tell us some things we're doing great. But that improvement part is really important, because that feedback can make a huge difference in terms of you doing a really better job of being really flexible and responding to it. I kind of have a saying, if I hear it once, I'm like, okay, take it as a point of information. If I hear it twice, I act on it immediately. Okay? Things that don't work. These are the things I would absolutely avoid if you don't want to fail in DPC. One of the things that I have historically done is every year, the last week of December, I sit down and reflect on the year before. And January 1st, Susan at my office always hates this because she knows it's coming. The first week of January, here's the new policies and procedures for the next year. And what I do is I look at what worked last year, what didn't work, and every single year I hone that edge of that knife a little sharper. So we've done everything you can imagine in 17 years. We've dispensed from the office. We've charged no fee when people come in. We've charged a fee when people come in. We've done enrollment fees. We've not done enrollment fees. We've done all these things, and every year we've evolved it to what really works the best for us now. And I encourage you, once you're in your practice and however you set it up, every year you need to look back and say, okay, what didn't work last year? And feel very free, because you are. The beauty of DPC is you're independent. You can change whatever you want. Be willing to go back and change that and make it better for the next year, and your practice will just get better and better and better. This is another one that's been mentioned before, and that's practicing in isolation. I had no choice but to practice as an isolated DPC physician way back when, okay? Because nobody else was doing this crazy stuff, okay? But you guys don't have to face that anymore. In most communities, not all, but in a lot of communities around the country now, there are a few DPC docs in an area. You guys need to know each other. They are not your competitors. I wouldn't see it that way. They are actually your teammates in getting that community to understand, appreciate, accept, and accelerate this model. And it is better to have DPC docs around you, believe it or not, than to not have DPC docs around you. So don't be in isolation if you can avoid it. We work on a national network basis for several things for the grant and some other stuff, and that's always good to hook people up with local folks. But you guys can do that locally too. You can establish local networks of docs in your area. You guys get together. Let's just say, for example, let's say the hospital, because you don't work for them and you don't use their EMR, you're having trouble getting medical records on your patients. Well, my feeling is probably the other DPC docs in your area are having the same problem. All of you guys go over to the hospital and meet with their physician relation liaison one day and say, hey, we're all having this problem. I guarantee you it will get changed. And it's harder to do that when you're in isolated practice. Paid print ads, they just don't work. Don't spend a lot of money on traditional advertising. I just haven't found it to be effective. When we had those intake forms and did newspaper ads, nobody ever said it was from that. The yellow pages, they're obsolete. right? Absolutely nobody uses Yellow Pages. They use YP Online maybe, but nobody uses Yellow Pages. We are not even, this sounds crazy, but we are not even listed in our phone book. We have an unlisted number. So we're not in the Yellow Pages, the White Pages for our community or the surrounding area because we won't even pay for the $10 a month listing because we don't need it and nobody uses it anymore. And if you guys look in the Yellow Pages under physicians and surgeons and you look through there and you say, oh, well, Dr. So-and-so's not in there, Dr. So-and-so's in there, why am I the only doctor on this page? Because nobody uses it anymore, right? So don't pay for that kind of thing. And then we already talked about complicated membership plans. Now, if you're a mature practice, if your panel's full, you've added another physician or whatever, and you want to start adding tiers and making your membership plans more complicated, that's fine. And it actually works well in a lot of ways to have different tiers, adds value. Some people want different kinds of memberships. That's totally good. Just don't do it initially. And then you want to make your value clear. What do you offer? Access, customer service, privacy, and enhanced technology. Now, the enhanced technology, there are a lot of traditional practices doing some of that, but they're not typically doing free telemedicine, texting, email. Some of them are, but not most. And the privacy part, I want to talk about a second, because this is not most patients, but there is a significant percent of my patients that I'll call off-the-gridders. And a lot of these are older patients. And they say, look, I am so sick of the government knowing everything I do. I don't want them to know when I go to the doctor. I don't want them to know what scans I get done. I don't want them to know what blood test I get done. That's their right. And so if they want to be off the grid and they don't want claims submitted and all that kind of stuff, that's actually something you can sort of market in some way and say, look, I'm not going to share any of that with anybody. Your personal identifiable health information stays right here, and I'm never sending it on a claim to anybody, right? So privacy, there's a certain percentage of people that really value that. And I'd say especially people who are maybe 65 to 80. There's just a group of folks who are very skeptical of all this billing and coding, and even though some of them have great insurance, they'd say, no, I don't even want anybody to know I got medical care. Now, of course, what happens to you guys in some situations, as happens to me, is I always get stuff from insurance companies saying, utilization review consideration. Your patient hasn't had a hemoglobin A1C in 10 years. And it'd be like from United Healthcare or somebody. Well, United Healthcare thinks if they didn't pay for it, it didn't happen. I've been doing A1Cs quarterly on that patient for 10 years. It's just they never saw a bill. So, a lot of people really value that privacy. They don't want their insurance company or whatever knowing about what's going on there. So these are the things that are critical. If you do these and you provide good customer service and your primary focus is providing a great physician-patient relationship, you will absolutely succeed in DPC. And I think Emilie and I are going to take some questions.
I just wanted to say one thing. We're in California, so the overhead's high for rent. So we are in a non-medical space. We had to do some tricky things with licensing to do that, but that saved us money. And we're also in about 1,200 square feet. We have 800 patients and 2 providers and someone that subleases. And we're still able to make it work because you see about 1% of your population a day. So my husband and I share an office, and we can do that because we trust each other. But we're able to operate 800 patients out of one exam room. So
we're going to take a couple of questions, and we'll both answer these. But the first one is, how and when do you increase membership fees? And they're asking, is it a certain amount every certain number of years, et cetera? I would say for myself personally, number one, I make sure it's something the market would endure. And sometimes I bounce that off people in the office. I'm like, hey, what do you think so-and-so would think if we went up $5 a month on their membership? And they'll tell me, quite frankly. Susan might say, oh, they're gone. They're stretched. They're doing everything they can right now. They can't do anything more. So 2 things. Number one, any patient that's a member that has kept their membership continual, we grandfather permanently. So as long as that membership doesn't lapse, they're at the same price we've always had. So I have some people who are on a pricing option from maybe 7, 8 years ago that have just kept their membership continuous that whole time. And that's fine, because the difference in pricing doesn't mean much. But I would say, as long as you're keeping up with cost of living increases, that would be what you could do. Now, in terms of sustainability, I would not do that until you're getting fairly full, because you don't want to discourage growth at all until you're getting to the point where you're very comfortable. And then you're in demand. And people talked about a waiting list, which actually creates more demand. that's the point that you increase your prices. And then I always also have options for people with the increased prices that can't afford that. So sometimes people ask about sliding scale, and we have something like that available. So
yeah, we've been in business for 2.5 years, so we haven't raised our prices yet. We started with multiple tiers and took away the lower tiers for new people coming in because we realized 4 tiers was ridiculous. It was more for me out of fear. And so our thoughts are that probably within 5 years we'll do a raise on everybody of somewhere around $5 per member per month, which what we hear is that the number of people that will drop after you raise the prices will not be enough to make it a negative impact, that you really end up coming ahead when you do that.
So the other question real quick is, are there any specific demographics or areas that make DPC more difficult to be successful? I would say that 95% of the places in America this works okay. There are definitely places it works better than others. The thing that might surprise you is in affluent areas is actually one of the worst places. Because in affluent areas, typically people have great insurance, and they pick their provider going through their insurance manual, and your name's not there, so they'll never see you or find you. And since all their neighbors have insurance, they'll never find you either. And so it's actually harder in a really affluent area. Rural is okay. Rural works as long as there's enough people to fill your practice. As long as there's enough bodies within a 10-mile radius to actually fill your panel, you're okay. I have known of one practice failure in an area that's incredibly rural called Bald Knob, Arkansas, where there just wasn't enough people within 15 miles to make a full panel if 100% of the people joined. So you do have to have patience around. I don't know what
So to give a little counterpoint, we're in a pretty affluent area. We're in Newport Beach, Orange County. It's a lot of money. And we have a very diverse socioeconomic panel, and we've been very successful in the time that we've been operating. So I think it can be successful anywhere.
Mm-hmm. All right. Can everyone thank Dr. Forrest and Dr. Scott for the
All right.
wonderful
Thank
advice?
You guys.